Good morning. First of all, thank you all for coming on a Saturday. We have constructions around. We started this about 11 years ago with maybe having 15 patients in the audience and families. Now we had about over 100 RSVPs and easily probably about 80 right now. So some may be coming. And based on requests from actually prior sessions, patients were very interested in self-management, particularly talking about medicines and interactions and side effects. And what does the doctor want to know when you go to the clinic? So the first part will be about patient self-management and what we expect you to do that will help you at the end to manage better your congestive heart failure. The second topic is instead of talking about all the different kinds of diet, I just pick one Mediterranean diet, which is pretty much what you ate this morning or you're eating right now. I hope you enjoy it. And we're going to talk about health benefits of that and how to do it. Okay, so I'm going to start with a fun question. Who said what nourishes me destroys me? And believe it or not, that's Angelina Jolie. And while I acknowledge she might be a controversial personality, she may have gotten it right with this one, that's for sure. Basically what feeds us in low amounts and moderation could be healthy for us. It could be actually poisonous if we overdo it. And if I were to talk about signs and symptoms of congestive heart failure, basically it's a little bit like the 7 dwarfs of congestive heart failure. This actually is adapted from a slide that was 7 dwarfs of menopause, and pretty much is similar. It's just a matter of time. Basically, you can get itchy if your liver is congested and you get jaundice. You can get bitchy, mood changes, sweaty from adrenal activation, sleepy, your heart is not pumping enough blood to the brain, bloated when you have fluid in the stomach, forgetful, you can concentrate, and psycho when you're really frustrated because this is an extremely difficult condition to manage on long term between many providers of care, hospitals, and also it's extremely complicated for the caregivers. So if I were to simplify the signs and symptoms that one may feel with congestive heart failure, you can have the overwhelming symptom be shortness of breath, but the secret is to compare how is your breathing now with whatever exercise you do now, how it was 6 months or a year ago. And when we have chronic congestive heart failure, that means it happens slowly over months or years as opposed to acute, which is over a few days. The body actually will adapt, and it can happen that you may see absolutely no fluid anywhere, but you notice that whoever has that condition will do less and less throughout time. So my usual question is, okay, what is your most activity you do in a day? And if they tell me, well, I go to the mailbox and come back. All right, but it could be, well, that's what I always done for 10 years. And then ask, how about a year ago? Were you going shopping to various places? Or no, I stopped doing that. It was just too much exhaustion. So that tells me that's an equivalent that things have happened solid there. Swelling of the feet and legs. Everybody pays attention to that because we have problems putting on the shoes. Unfortunately, by the time you have the swellings in the leg, fluid in the legs, you already have 5 to 10 pounds of fluid that has already accumulated in the main central organs, what we call central fluid in the lungs and in the stomach. So you can't wait really until fluid gets in the leg. It's already advanced. But nonetheless, it's something that we should signal us. Lack of energy all the time, and welcome to my world, okay? Heart, it's exhausted. It has to, I will show you, it has to work once you have congestive heart failure under adrenaline, like you're running a marathon 24 hours around the clock. So that's an overwhelming symptoms, for somebody who has chronic congestive heart failure. Difficulty sleeping at night due to the breathing problems, or sometimes you may not be aware of breathing problems. For example, at night we actually have fluid that moves from the legs into the lungs and the stomach. So when it moves in the lungs, you may feel that there's a fluid going in the lung. It may manifest as a dry cough, for example, nagging cough. You can't really lie on your back, so then you start to use more pillows to prop up, or you can have just anxiety. Anywhere between that. It can be very nonspecific anxiety because fluid in the lung is not tolerated. It will trigger from the brain adrenaline release. So it's like you just had 2 coffees before you're trying to go to sleep. And that could be part of that. But you notice that if I give you a sleeping pill, that actually cuts the adrenaline off and actually you can sleep. And you keep asking, well, I can't sleep without that. But that's just more solid sign that you have too much fluid that accumulates at night that shifts from the legs during the day. And the other way, vice versa happens too. I always get puzzled when my patients and sometimes even doctors say, wow, I only have fluid in my legs just during the day, at the end of the day. In the morning, it's just fine. Yeah, you just shifted the fluid into the lungs, and now you're shifting it. It's there. I don't care when you see it, during the morning or in the day. That means we got to take it out. You can have, if you accumulate fluid in the stomach with time, and this is probably one of the most subtle aspects, because I cannot see it as a physician. We are very limited in really diagnosing fluid in the stomach by just looking at you. At least in the lungs, we can listen with the stethoscope, but you can feel it. And the way you feel it, either you or your spouse will notice you're starting to eat smaller and smaller portions. And usually the dinner is the one that it'll go away first. If this continues, you accumulate more, the lunch goes away, and eventually the only meal that you really eat full will be the breakfast. Why? Because breakfast is after 8 or 10 hours that you didn't eat, so you have plenty of room, all right? So those are more subtle things, and if you continue and you accumulate even more fluid, you can start having nausea, eventually lose appetite, but that's in advanced stages. And you go to ER thinking there's something going on with your stomach or gallbladder, but it's not. It's actually congestion. And again, cough, whether it's frothy or not, that's more of acute, but dry nagging cough, particularly at night, it could be from accumulation of the fluid, all right? And yes, kidney loves, particularly congested kidney, loves to pee at night. So if you notice you have to pee a lot at night, it's because when you lie flat, the kidneys, all the blood goes into the kidney as opposed to skeletal muscle. They'll finally enjoy enough blood supply, so they'll start to try to compensate and release the excessive salt and water that has been accumulated during the day. You can have confusion, impaired memory. This is usually more advanced stages. And a sudden weight gain, meaning 3 pounds maybe in a day or two, or 5 in 2 days, that kind of stuff. Basically, if you feel any of these symptoms, this is similar. The fluid in the lungs actually can manifest also as chest heaviness or pressure. But if we had the prior heart attack, you start worrying, oh my God, am I having again heart attack? What's different compared to heart attack, this is constant. So you won't be quick in and out for 5 minutes, 10 minutes, and goes away. It will be constant. It happens over days that can progress. At one point, initially it's with exertion, eventually you just at rest. And guess what? It goes away with nitroglycerin, just from like the chest pain from the heart attack. So it works on the same mechanism. So keep that in mind. I talk about feeling full too early. That's a sign of congestion in the stomach and the liver. You are getting more and more short breath with less exertion. And anxiety and insomnia at night, that could be a sign, or dry cough, that could be a sign of fluid in the lung. Have a lot of patients who, after they accumulate already 15, 20 pounds of fluid, they decide to just move in chair and sleep in chair because it's more convenient. Why? You get your fluid staying back into the legs and sleep that way, as opposed to having to be short of breath when all that fluid shifts when you go in bed. So these are more subtle ways, and believe it or not, you will be more able objectively to identify and tell us about it. Of course, we know how to ask the questions too, than me being able to see it if it happens slowly over time, weeks or months. And we have the weight gain as a rule, 3 pounds in 2 days. I want to tell you only 20% of the time that actually happens. You can still have fluid accumulation. The weight doesn't necessarily change. And 80%, if you just rely on the weight changing, you may not, and not on your symptoms, you're not, there will be fluid that has accumulated, causes issues, and we still need to deal with it. So only in 20% it happens, all right? So I'm going to talk about medicines, our poisons, our drugs, and these are necessary evils. Why they're necessary? Because actually we have 30 years worth of experience and research done that shows that does improve survival, does prolong life, better quality of life, keeps you out of the hospital, everything you want. All right. There are also poisons because there is no free ride. There's always a side effect. And the only reason, my purpose here is not to give you a whole lecture about 10 drugs that are happening here. I cannot stand lectures. My purpose, though, is to educate you, because if I were a patient, if I try, suddenly you have new onset congestive heart failure, see Sorescu, and I'm going to put you on 5, 6, 7 new drugs. Like, oh my God, do I have to take this for the rest of my life? And then you go home and you start Googling each and every medicine, or you start looking at in the small letters what it says. I mean, there's a pile of 20, 30 different adverse reaction. I think you'll freak out and you'll never take the medicine, okay? So what I did here, I actually sorted out what really actually happens more frequently and things that really matter. And also, the purpose is for you to recognize if there are side effects, bring it to us. And I promise you 95% of the time, there is a way around that to minimize the side effects, either switching to a different medicine or go there. And the purpose is to get knowledgeable and not panic about it and work with it, as opposed to just completely stop it or avoiding it. Now, in order to do that, I'm going to have to teach you at least what I teach the medical students in the first year of medical school. But it's going to be in more of a common language. So basically, the way it works, once the heart is weak, and I put here, on the echocardiogram, we get a number called ejection fraction, which is less than 35%. Normal is about 60%. It's about half. Okay? Once you get to a weak heart, in the body, there's a trigger for mechanisms that will go on their own, no matter what we do, unless we fix that ejection fraction, even if you don't have another insult. In other words, you had a heart attack, you have an ejection fraction of 35%. Let's say you never have another heart attack. That 35% will not stay by itself. Will go down eventually to 30, 25, because of some compensatory deleterious mechanism that happens the moment your heart gets weaker for the same size body. And the way it works is, whatever happens, if anything is wrong with the heart, the brain is the first to know. Why? The brain is the biggest, the body, basically is the chief of the whole body, because it doesn't tolerate to have low blood supply. So we'll know that. And once it knows that, it's going to activate a hormone called adrenaline. We all know about adrenaline. We activate that when we run, when we're stressed, when you, unfortunately, adrenaline, when it comes to heart failure, it's constant. So if I were to just run, I'll have it activated on and then off. Then I relax and it goes away. The heart can put up with that. But if it's constant, day and night, particularly when you run, then actually it's been shown that it kills the heart cells. So this is one of the mechanisms how we, even if you don't have another hit on the heart, it will continue to progress unless you take a medicine that will put a protective shield around the heart against adrenaline. So adrenaline is bad for your heart if you have congestive heart failure. All right, and what kind of medicine is that? Anybody knows? We call them beta blockers. Beta blockers blocks the receptors beta around the heart to put the protective shield around the heart from adrenaline. Okay, those are important, and we'll talk about those. Now, the second one, the second thing that the brain does, it will activate, it will tell the kidney, hey, you're not going to get enough blood supply. All right, why is it telling that to the kidney? Because kidney is in charge of maintaining the blood supply in the body. In other words, how much fluid we have in the system, and which is normally about 5 liters. So then kidney will then produce two hormones, angiotensin and aldosterone, which you don't need to remember. All you need to know is that we have medicine that blocks the angiotensin, and we have medicine that blocks aldosterone. And this is why when you sign up to, whether you like it or not, to have congestive heart failure, the first thing you're going to see me, I'm going to hit you with 3 medicine, because this brain triggers 3 different hormones. They're going to then work on the heart. What the angiotensin does, it grows the heart, makes it bigger. Remodeling is wonderful in your house, but it's actually terrible in the heart. You don't want the heart to enlarge, because the bigger heart, it's a weaker heart by definition. It has to work harder. All right, you want a heart to be small and strong. And why is angiotensin doing that? Actually, angiotensin is an essential growth hormone that we use in the fetal life. That's how we grow heart and vessels and kidneys in the fetal life. All right, and then basically the brain and the kidney is going to do what it used to do. Okay, heart is weak, we need more heart. Therefore, it's going to activate this. But that's good when you're in the fetal life, because your heart has to grow. Not good when you're an adult. Okay, and also raises the blood pressure, which will make the heart, pump work harder, and then secretes another hormone called aldosterone that causes sodium and water retention. In other words, a kidney that does not senses that the heart is not good, will forever retain sodium and water until the heart gets better. So anybody who's got congestive heart failure, know you're super sensitive to salt, no matter how you turn around, sodium mainly. And sodium, the body doesn't make the sodium. So there you go. That's the first thing that we need to know. There will be hormones that activate and do that. So I hope this wasn't too complicated. Well, good. All right, so now we're going to go over the actual medicines, names that you probably are familiar with. All right, beta blockers, 3 main ones. Carvedilol, metoprolol, and we call it XL or succinate, not the tartrate, which is the short-acting version. That's not good. We want the one that you take it once a day, not 2 or 3 times a day. Bisoprolol is another one. These are the 3 main ones that are approved in the United States for managing congestive heart failure with low ejection fraction. And if I were to pick one that no matter what you should never drop, is this. If you tolerate them, don't stop them. Even the heart gets better, because it is the single most important to improve the ejection fraction. Remember, adrenaline kills the heart cells. It doesn't just push them a little bit. So it's very important. The other ones are, we call them angiotensin converting enzyme inhibitors or ACE inhibitors, but bottom line, that's the doctor's language. In your language, it's like lisinopril, fosinopil, captopril, those kind of names. All right, and more recently, another agent that came on the market is Entresto, which is a new kid on the block that, of course, is supposed to be, it has been shown to be superior to lisinopril, but the price moves from $4 a month to $500 a month. And with copay, even if you have insurance, it's still anywhere between $40 to $100 a month. All right. The next class, which is the same like the ACE inhibitor, works on the same angiotensin, actually blocking the actual receptor. Not this one blocks the production of angiotensin, the ACE inhibitors, are the sartans. And in general, we reserve the sartans for those who are intolerant to the ACE inhibitors, to the lisinopril, captopril, or Entresto. Losartan, valsartan, candesartan, anything that ends up with sartan, that's what it does. Who are intolerant, usually the main intolerance will be dry cough from the ACE inhibitor, rash, face swelling, that kind of stuff. The third agents, remember I was telling you there's a third hormone, aldosterone. We need to inactivate that too, because that causes heart scar formation in the heart. That pretty much makes the difference between reversible and irreversible. And it's called spironolactone and eplerenone. And in general, these are not used so much, but although really they're super indicated, because we're all worried that potassium may go up. Doctors are not very familiar. But really, anybody who has got an ejection fraction less than 35%, unless they have some major kidney problems, should be on this medicine too. Hydrazine and isosorbide are usually, or a pill called Bidil, I'm going to talk about, and the famous or infamous diuretics, which we're going to talk a lot about it, okay? And if I can get you all, on all these medicines or at the proper dose, which are quite a few, if we repeat the echocardiogram in 2 or 3 months, actually, on average, the ejection fraction will improve by 10%, all right? I will say a third will get better by 10%. If we caught it early enough. A third will stay the same, and it's still a win, because you can live with an ejection fraction of 30-35% for the rest of your life, as long as you manage it well. And the third will get worse if I got it, at the very advanced stages, like ejection fraction was 15-20, I couldn't fix what's causing it, there is no lifestyle changes. All right, so we're going to talk first about beta blockers. The 3, carvedilol, metoprolol XL, and bisoprolol, as I mentioned, is the single most important medicine to improve your ejection fraction and your heart function, right? It puts a protective shield against adrenaline around the heart. But in order to do that, you have to actually we start usually at the low dose, and you have to go to the target dose that's shown to do the job, all right? So just because you're on it, but if you're taking carvedilol, it's supposed to be 25 twice a day, and you're only on 3.1 to 5, you really don't get the benefit. It's like the house mortgage. It's supposed to pay $1,000 a month. You just give them $100, it's not going to happen. You're still going to be evicted, okay? It's the same thing. To do the job, you have to give enough to protect enough the heart from adrenaline is released by your own body. This medicine also helps to control the heart rate in general. A weak heart, even a healthy heart, likes a lower heart rate. We like to be in the range of 60 at rest. We don't want, if you're at 100, 110, when you just say high, that's just not good. that tells you it's advanced heart failure. And so, of course, the slower the heart rate, the less heart has to work, and the better it's going to be. Initially, a lot of patients can be intolerant to beta blockers. The most frequent side effect is actually just being tired after you start it. And you have to think this way. All right, imagine the heart, it's a horse. Body is the carriage. How does the horse know to pump? By being whipped by the body, by the carriage. And the whipping part, the whip, is actually this adrenaline. So suddenly I got a weak horse, three-legged. I have the same carriage, all right? And if I want the horse to last longer, and again, heart has to work 24 hours around the clock for 100 years, then I need to give a break to the horse, not keep whipping it. How do I give a break? I put the protective shield with the beta blockers, so the heart does not see the whip. But if the heart does not see the whip, the body, the carriage, will not be happy. It's like, I can't do anything the rest of it. And I say, that's okay. Listen to your heart. Don't do much. And what happens is, after 2 weeks, you'll see that that's why we start with the low dose, that we can build it up. Suddenly, the heart gets a little stronger because it's rested. And then suddenly, what used to be extreme tiredness with low dose, no problem with the higher dose. But you have to be patient with that. So this is something that actually, they work. They do the job. Okay, so unless you have extremely advanced heart failure, you need a heart transplant. Most of the time, I can work with the patients, switch them around. Some of them may be dizzy from cardio. I switch them to bisoprolol. I find a way how to get them tolerate and gradually go up on the dose. That's important. Now, for men, these beta blockers has been incriminated. They cause erectile dysfunction. Okay, just forget about that. It's a myth. It's not true. Why is not true? Because also the first symptoms of congestive heart failure is erectile dysfunction. Okay, so bottom line is the underlying conditions that causes a weak heart who can't pump enough blood that causes the issue, and then you start to pay attention because I give you a beta blocker. Temporary makes it worse, but once it improves the ejection fraction, everything is solved. So you got to be patient with that. So these are the two major side effects. The rest, you can, like with any drug that we give you, you can have rash or allergy, but that's very person-specific, easy to identify. You know, you stop it, it goes away. We switch it to a different one with different chemical, so it's not a problem. All right, but that's it. Whatever you read otherwise on Google, just get rid of it. It's just, you know, it'll just scare you. That's all. All right. So, next class, angiotensin was. So the first hormone was adrenaline. That's bad for you. The second, hormone was angiotensin. So we block the prevent the angiotensin formation by using this ACE inhibitor, like lisinopril is the most common, captopril. And Entresto, it's a little, it's a little different. It basically blocks the angiotensin receptors, but also uses another medicine that actually helps to prevent the effects of the angiotensin too. So what they do, they shrink the heart. Remember, we don't want the heart to start enlarge and grow because it's a pathological growth. It actually grows into a weak heart. The fetal heart, the baby heart, is actually a weak heart. But it can be a weak heart because it works on the low pressure system in mother's belly. It's 5 times less, so it doesn't have to be a strong heart. So anything that grows immediately gets weak. Just know that by default. So we want to shrink it, ungrow it, and so it gets stronger. That's very important. And that's how it works. It also lowers blood pressure. We want to lower the blood pressure just to about 90 or 100 over 60, 70. We don't want to overdo it. That could be a side effect. You get dizzy. But that's important because it's less work load for the heart. Also, because angiotensin activates the aldosterone, which causes sodium retention, you also have an effect of not retaining so much salt and water. And the main side effect is actually a dry cough. They can happen in 1 out of 10 patients, usually women. All right? But it can happen to a man too. You can get a rash, you can get lip swelling, facial swelling, shortness of breath. That can happen anytime after the first dose, or it can happen 4 years later. So just because you haven't had it when you start taking it, but it happens later on, is not the true allergy. It's more of it's a certain chemical that accumulates in the body that has to reach a certain threshold. Okay, so if you feel this particular dry nagging cough, particularly at night, but it's also during the day, it could be related to this, and tell your doctor so we can sort out, make sure there's no other reason for dry cough. Why? Because I have alternative. We can switch you to sartans. All right, and of course, one of major side effect that happens with this medicine, because it will lower the blood pressure, it can lower it too much, and sometimes we need to adjust, either cut the dose or do something else to go around that. And this usually happens, especially if you have a concomitant infection. And there are other things that are going on with your body that will also lower the blood pressure. Anything that causes fever will lower the blood pressure too. So a lot of times we'll have to step back and stop this medicine for a while until you get over that part, and then we can go back eventually and you tolerate. All right? And rule of thumb for those who are on Entresto, if you are intolerant to lisinopril, you're intolerant to Entresto too. Works to the same mechanism. Okay. So how are we doing so far? Is this too complicated and too detailed? It's okay. Something good. Yes, sure. Maybe it'll be better if you can keep it at the end, because I have a lot of material to go through. All right. Sartans. Sartans, you take them to block the angiotensin receptor if you don't tolerate the lisinoprils or Entresto. They do the same what the ACE inhibitor will do. They do not cause dry cough. It's extremely rare, so that's why we use it. And they do the same in terms of side effects will be similar like otherwise, except the dry cough and the angioedema, the least swelling will be the same like the ACE inhibitors. You can get also dizzy. Lately, in the past year or so, there have been some recalls on the sartans, mostly related to chemicals that were contaminated from the manufacturing process. And there are so many recalls back and forth, I stopped worrying about it. The bottom line is we need to check with the doctor, whatever lot you have from whatever pharmacy, to make sure you're not, it could be losartan 50 milligrams that works fine from this lot but doesn't work from this lot, depending on what company is manufactured. But just be aware, it has contaminants with a substance been associated with liver cancer. The risk of liver cancer is extremely, extremely low. However, it's something that, if we can avoid and get around that and find the proper lot, that'll be better. Yeah. Now, the third hormone, remember, was bad, the aldosterone. We try to counteract that too with spironolactone and with eplerenone. The spironolactone basically works on the receptor for aldosterone, and it's been clearly shown that prolongs life and reduces and improves ejection fraction by actually reducing the scar in the heart. When I talk about scar, it's more of a microscopic kind of scar. In other words, the heart is a muscle. You don't want to be like skin and not being able to move. If you have a scar does not move. So you really don't want to replace the healthy heart muscle that's left over with the scar, number one. Number two, that also makes the difference between a reversible ejection fraction and an irreversible one. So it's extremely important. It also, for those who have to use furosemide diuretics, they can drop their potassium. The added benefit is it actually raises the potassium, so you don't have to take so much potassium supplement. Of course, if we start you on this, we'll have to check your potassium usually just once, about 2 weeks after. After that, if it looks steady state, we don't have to worry about it, okay? And one thing that happens to me all the time, I prescribe the spironolactone patient is also on furosemide. So, you go to the pharmacist tell you, oh, but it's also a diuretic. You don't need both, so cut my spironolactone and give the furosemide. And it's not a diuretic at this dose, okay? It's just for heart protection. So you need to know that. Even if you were to Google it, and pharmacy is old school, yes, it can be a diuretic, but usually we'll have to give it not 25 milligrams a day, anywhere between 100 to 200 milligrams a day. So it can be a diuretic, but a way 10 times higher dose. That's not the purpose here, okay? And as I mentioned, changing the potassium, it could be a good thing, particularly if you have to take a lot of potassium supplements because you use the diuretics. But we don't want potassium to be too high because your heart can stop. That's why we usually just monitor when you come and see the doctor from time to time. Not an issue. As long as you come to your visits, you don't have to worry about, oh my God, I'm going to die of too much potassium from spironolactone. It's not an issue. Those who can run into high potassium problems from it are usually those who have diabetes that's poorly controlled because their kidneys have already a tendency to retain potassium. And again, we can identify that and figure that out. Okay, now, there is one major side effect with spironolactone, particularly this time for the men, not so much for the women. It can cause actually breast tenderness and enlargement. All right. Basically, it's like you're at puberty again, but once you have them enlarged, they'll stay like that forever. You'll have to basically have a surgical resection to remove it if it really bothers you. The secret with that is that if you have those symptoms, 1 out of 10 men in average, it happens usually 3 to 6 months after you start the medicine. So it's not right away. So by then, doctors forgot about that. Of course, you as a patient, well, I don't have any side effect initial. Obviously, it's not from this. It's just notice that you're starting to hurt, okay? When you put your T-shirt on or anything like that. So try to tell us when they're tender, because they're already swollen, it's too late, all right? If they're tender, it will go away. We can switch you to the new kid on the block or a relative new kid, eplerenone. That is the same like spironolactone. It doesn't cause that, and you'll say, well, why on earth don't you put me straight on that? Very simple, money. It's $300 a month as opposed to $4 a month. Also, the copay, even if you have insurance, copays anywhere between 50 up to 100. So that's why. Otherwise, of course, I would rather start with the eplerenone on everybody. All right. So hydrazine and isosorbide dinitrates. These are a lot of pills. This has been proven, particularly in patients who are African Americans with congestive heart failure, on top of the other medicines, to actually improve ejection fraction and prolong life. Unfortunately, to get that benefit takes 6 to 12 months. So this is long-term. It's not short-term right away, as opposed to the other medicines. They work a lot faster, and it's a lot of pill. I don't know if anybody's on hydrazine. It's 25 milligrams pill. You got to be at 100 milligram dose, 4 pills each time, 3 times a day. And then separate, that's just the hydrazine. And then you have the isosorbide dinitrate, that's 2 pills, 3-4 times a day. And now they have a combo pill called Bideal. It's only 2 pills 3 times a day, but it's still a lot of pills, okay? And it doesn't make the life easier. So this is not my first to start. I start you first on the 3, and then particularly if you're African American, have a lower threshold to start you on these 2. But you got to see, this is for more OCD kind of patients. You really want to, and we're already, the heart function has not improved. In other words, we have to have more motivation to do that, okay? Now, the main side effects of a hydrazine is dizziness, severe dizziness. Okay, and it can happen with extremely low dose. And guess what? The people who need it the most, African Americans, the one more likely to get the side effects. And I had a patient I never had any patient threatening is going to sue me, but this particular patient took 1 little pill of hydrazine, passed out. Sorescu, if you ever put me on that medicine again, I'm going to sue you. Okay, and that can happen. All right, it's serious. It doesn't have to be dizziness. The first symptom can be just total collapse. All right, so pay attention to that and let us know if you started on that medicine. And it can happen up to 1/3 of the patients. Most of the time that it's actually limited, just a little dizziness when you stand up, nothing major, but it can happen in more extreme situations. And the nitrates, the isosorbide, just like anybody's ever used nitroglycerin, can get a headache. Now, there is some good news about this. If you do tolerate them, after 2 or 3 weeks, actually the symptoms get better and the body gets used to. But that's usually the major limitations. And the good news as opposed to the ACE inhibitors and the sartans is that which may affect the kidney negative or the diuretics. This one does not, the Bideal does, or hydrazine nitrates do not affect negative the kidney. So you see we have options that we can flip the medicine around depending what's the major side effect you have there. All right? Okay, so now my all-time favorite topic, diuretics. And this is where everybody's going to agree to disagree. You're going to have patients who are unhappy with diuretics. There are patients who are super happy with diuretics. You're going to see doctors who hate diuretics, like the nephrologists, the kidney doctors, because kidney does not like diuretics. You're going to have cardiologists who are very happy with it because it helps with the congestive heart failure. But I think bottom line is there is no free ride here. And the reason why there is controversy, because it's absolutely by design, diuretics are designed to hurt the kidney. It doesn't matter what dose you take. There is no doubt about that. It doesn't mean it will cause irreversible permanent kidney damage if you do it right. And the reason I'm telling you about this is I'm going to teach you how you can safely take diuretics without ever having to worry about that. And you can be both a cardiologist and nephrologist, a patient happy with diuretic and not an unhappy with. So bottom line is, first of all, the biggest myth is that it's a water pill. It's not a really water pill. Technically, it's a sodium elimination pill. It's a sodium pill. You take the pill to tell the kidney to get rid of the sodium that has been excessively accumulated. And remember, the kidney does that automatically if it has congestive heart failure. It's been told by those hormones to retain sodium. So it's trying to actually balance out what's wrong with our congestive heart failure, telling the kidney. Unfortunately, it's not a perfect, so the water just follows. It's just chemical extraction. The same way, you're not going to see a doctor in a patient's room unless there is a patient in that room. The doctor will be the water, and the patient is the sodium, all right? But bottom line is not the perfect science, because ideally what I like to do, if today I retain 1,000 milligrams of sodium, I would like to use a diuretic dose and frequency that will just eliminate those 1,000. And this is where we start the life and hate relationship. If I can pick the dose and the frequency that just does just that, and you just get neutral balance at the end of the day, then there are no side effects. But if I pick a too high dose, then you get dehydrated and you get dizzy and it hurts the kidneys. If I pick too low dose, then it didn't do the job. It still caused the damage, because kidney does not like to just look at the diuretic. There'll always be a trigger from the kidney. Believe it or not, when you give the furosemide, the kidney, at any dose, the kidney will activate more of those neurohormones, the renin-angiotensin. So anything you throw, any dose of furosemide or any type of diuretic, throw at the kidney, will activate those more renin-angiotensin, which then in turn will worsen the heart failure and the congestion. So might as well decongest and get some payback from that, okay? So that's the secret. So the usual names, furosemide or Lasix, torsemide, bumetanide or Bumex, hydrochlorothiazide, chlorthalidone, all right? What kind of side effects we have? How many of you have been on any form of diuretic? Raise your hand. All right, so at least half, 2/3 of you. All right, so you know exactly what I'm talking about. You feel drained, you get cramps, you get gout attacks. You can get ICD shocks from it. I'll show you, because it drops your potassium. That triggers your irregular heartbeat. And you can get dizzy if you're too dry. It's a necessary evil, as I said. Why? Because heart and other organs, the stomach, your gut, your lungs, need decongesting, need to get rid of the excessive sodium water so they can function properly. And you can stop this vicious circle, but we don't want to take too much off, and that's the secret here, and say, well, it sounds like this is not science, it's more like art. No, it can be perfect science, and I'll teach you how, all right? Because you know your body better than anybody else. Just got to give you the proper tools. So first of all, to begin with, I told you sodium is not made by the body. The only way it can come is either through the mouth, believe it or not, with food or pills. By the way, any pill that eats a pill, it's solid. The main ingredient to preserve it is sodium. So you can actually have plenty of sodium just from our pills. Number two, doesn't mean it's, we should, that's why we try to minimize them, but that's important. The second thing is you can actually get a lot of salt and sodium when you visit emergency room. All right, emergency room is designed for a crash kind of situation. On ours, your blood pressure is a little borderline. They'll just put a bag of fluids immediately in you. It doesn't matter before you open your mouth. And the fluids is normal saline. Normal saline means that there is about 9 grams of salt per liter of fluid. All right. For 1 gram of salt, when you leave the ER, you will accumulate 1 pound of water if you have congestive heart failure. So you're going to have, a week later, 10 pounds fluid overload from that. All right, so in other words, doctors can give it to you, all right? And of course, it was for a different purpose. Your blood pressure is low, it's important. But then after that, after you got better, we got to take it back out, and we need to know about that, all right? So otherwise, if it's in your hands and you haven't seen the emergency room or the hospital to be contaminated by our not-so-normal saline, okay, I tell everybody, ain't nothing normal about normal saline. Okay, it's too much salt. The secret is to actually, you can try to reduce the need for that water pill or Lasix by avoiding high sodium content foods. And really, the number one is processed part. And then you can afford to actually keep the diuretics at the minimum. Okay. Also, for those who really have just not good eating habits, and they just love Golden Corral or Red Lobster or Piccadilly, and that's about the reason why I use those culprits. Believe it or not, McDonald's is not the worst in salt content. Chick-fil-A is worse, by the way, twice worse, okay? I'm not saying you should subscribe for McDonald's instead of the Chick-fil-A, but salt-wise, that's why you like that chicken. That's the secret, okay? All right. Those actually need boosters. In other words, after a while, the body, the kidney will get used to what we call the loop diuretic, these guys, and then I have to give you another one 30 minutes before this guy to make it responsive again to the torsemide furosemide. And this is a bomb, okay? You're moving from a BB gun to an AK-47 here, all right? So you're gonna pee a lot. When you pee a lot, finally you relieve because finally it's working, but the catch is you're gonna lose a lot more potassium, magnesium, which I don't want you to lose that. And if your magnesium, potassium drops, guess what? Is going to be a problem, all right? So here is the not-so-perfect science behind it. If today I eat 3,000 milligrams of sodium and I have congestive heart failure, my kidney will let only 2,000 milligrams out, okay? All right? For some reason, it doesn't do. If you're normal and healthy, your kidney is happy, all right? You don't retain anything, then you eat 3,000, you pee 3,000, all right? And you can eat, if you go out to a 5-star restaurant, that all those steaks are amazing. They're 10 times saltier. That's why they're amazing. They're not better, all right? Then you can go up to 7,000, 8,000. Trust me, I've done that. I actually polled my patients. I make them write for 3 days everything they ate. And it was anywhere between and that was on they're supposed to be on 1,500 milligrams sodium restriction. And from the 50 patients that I signed up like that, even for the same patient, one day could have been 2,000, but the next day was 7,000. And then the next day was 3,000. And it's like, what's going on? You cannot have such an erratic behavior eating. Obvious must be something wrong, but maybe they forgot to put it in what they were. It turns out that there was 7,000. It went golden corral or red lobster, and that's the usual, and you name it, everything that's out there. I don't have to tell you. But that's huge amount of salt. I always say 1 meal eating out is like 20 meals eating salt at home. It's not how you think. It's not just a little bit, 20 or 50% increase. It's a lot, okay? And then you retain, even without, you're going to retain 1,000 milligrams. And again, you're not eating a lot of salt. I assume that pretty much if you just cook at home, that's without looking too much at the salt and not putting extra, you eat probably about 3,000 milligrams a day, all right? And you're going to retain 1,000. If you retain 1,000, for each 1,000, you retain a pound of water, all right? And this cycle can go on and on. After a week, you retain 7 pounds. And then you start to feel short of breath, start to have chest heaviness, all the symptoms of congestion, they gradually develop. So you may not notice, but if you compare yourself with 2 weeks ago, you're going to see the difference, all right? And eventually, you're going to see some fluid in the legs, and that's when people start to pay attention. Some of them have had fluid in the legs for years, so much that their skin started to have infections, breakdown, and so much that at one point, the patient got used to, but then the doctors start to say, well, I can't really fix this. And what do? They start to cover it. It's called Wunderwitz. That's where I say when the doctor goes in denial, instead of treating what's causing it, get the salt out and tell the patients you got to limit the salt, all right? And that's important. But it can be I've seen some extremes. And basically, I always say ankle swelling is only the tip of the iceberg of fluid accumulation. You're really drowning. And it's important to not walk around congested even if you feel okay, because that's the tip of the iceberg. That means your heart is already working under pressure. And if you walk around for 3 years, even haven't been in a hospital with fluid around, it's 50% you'll be less likely you're going to be alive as opposed to others who don't have that. I mean, in other words, the one who will live the healthiest will be the one who don't have to take the diuretic and they don't have congestion. Okay, so now let's say I just decided I'm going to go to Red Lobster tonight and I have congestive heart failure. Well, an average meal will be 5,000. I'm not talking about the others. You're going to pee only 2,000 because that's the kidney says I'm going to let go of 15, 20,000. The rest I'll retain. You're positive 3,000. You retain 3 pounds from one day to another. Okay. And then I'm going to use a diuretic, whether it's furosemide, torsemide, bumetanide, and I'll tell the kidney, hey, get rid of the excessive 3,000, get the water back. All right. And that's the ideal. But again, I may be using, if I use furosemide, that probably be 80 milligrams will cause about 1.5 liters of urine, which is 3 pounds. But if I use torsemide, that may cause a little more. It's more powerful than furosemide, the same with bumetanide. So we have to pick the proper dose, the proper type of agent, but usually you pick it up depending how much sodium the patient had. So if I have somebody who gains 10 pounds in a week, I got to give them torsemide or more, bigger guns. If I have somebody who only gains 3 pounds because it's eating, tiny little lady who eats just very low, then I can afford to get away only 40 milligrams of furosemide maybe a few times a week. So you see, in a way, it's not a clear science, not because we cannot make it, it's because we exclude the patient's will and lifestyle from our medical decisions. But if I see that every day you're going to keep your daily weights, I know I got you to the dry weight, and then I see, okay, I just pick a dose, furosemide, 80 milligrams every other day. And then I see at the end of the week, you gain 3 pounds, then I know that I have two options here. Either I go up on my 80 milligrams of furosemide, which I'll do it at least temporarily, usually for 3 days, okay? Or I'm going to tell you to cut the sodium. Okay, let's be a little more self-critical. Where did you eat out? Where did you get that excessive sodium? Try to, replace that. So if we work together, you're honest with me what you ate, and I'll give you some tips on how still get the food you like, but just in a different way that's not so salty, then I can afford to step back on my water pill. And the other way around, when everything is, there are plenty of patients, well, that's my only way I can socialize. I'm 75 years old. What do you want from my life? I can't meet with my girlfriends unless we go out, okay? All right? And also, I can't convince a poor woman at 75 who's cooked her whole life for 3 kids. Suddenly, she's enjoying retirement, got rid of the kids, doesn't have to cook anymore. Then it has to go out, right? Another reason. So, but I can, work with it. The funny part is, those who are my patients, they know how obsessive I'm going to ask you those questions. Where you eat, if I see fluid there. If I don't see any fluid, I ignore it. But as soon as I see fluid and you're asking for a water pill, then I get on to you, okay, tell me what you ate yesterday, what you ate for breakfast, lunch, dinner. And then, of course, they'll always volunteer with the healthy stuff. They don't volunteer with the other stuff. And I say, I can't really, so it becomes more of a parent-child conversation. Make sure you don't make me feel guilty about it, but it doesn't really matter to me. All I'm saying is, the only reason I'm asking, so I can give you tips. You like a certain kind of food, I'll teach you how you can still have the kind of food you like, the taste, but get a way around that and not get the salt part of it that makes you sick. Very simple, okay? So it takes 2 to tango if we want to minimize the side effects of the diuretic, and you have to be absolutely honest with yourself and the doctor, and what can you do within the limitations to try to diminish the role for these diuretics, okay? And that's why we fail. That's why I have people who hate it, people who like to go out. They love the torsemide. They're all just, actually, hey, they take it before they leave, and they, I'm not kidding you. This is a true story, okay? And there are others who are fed up with that because they get drained out, they get side effects, and they don't like it. So, but we can make it so it's not the enemy. But long term, if you actually abuse these diuretics, there are a lot of other side effects that one needs to know, all right? The main one being gout attack. How many of you have ever had gout attacks? Okay, 3, 4, 5, I hope. So, and this is the most excruciating pain one can ever have. Am I correct? All right. Everybody thinks it's the tooth abscess. No, it's nothing like this. It's a nagging, throbbing pain in your joint. You can't sleep at night. You can't move during the day. You can't take your mind away from it, no matter what. Okay. Why? Because the furosemide prevents the excretion not only of uric acid, and uric acid is the one that, if it accumulates, is going to start to go into joints, and then it's like needles in the joints, activates inflammation, all right? And it's a serious issue. Now, diuretics per se won't necessarily cause the gout. It takes, like I mentioned, 2 to tango. You need to have the uric acid coming from somewhere, all right? And it comes from fructose, okay? And everybody thinks it's meat, which indeed you can have it from meat, from protein catabolism, but most of the time, at least in nowadays, it's fructose. So anything that has high fructose corn syrup, juices, apple juice, orange juice, cranberry juice, where they put boatloads of high fructose corn syrup in it to give the taste equivalent of 8 to 12 teaspoons of sugar per serving. That's the source of it, okay? And if you were to cut that out, you'll be surprised you don't get the gout attacks from the diuretic. It may still happen in advanced stages, but extremely rare. So those are things that you can do before. But then what do we do after you get a gout? We give you steroids, because that cuts the inflammation. What does the steroid do? Can you retain again more sodium and water, and then more fluid, all right? We're back to the same thing. And then I got to give you more diuretic, and we keep going in circles. Unless you stop eating fructose and sodium, you're not getting out of this circle, all right? It's a painful circle. And then what happens if I keep going up on it? I start losing potassium, magnesium. What are the side effects of those? Leg cramps, all right? No fun if those who had it. And then what do? I give you potassium magnesium. Well, that causes diarrhea and stomach ache, okay? All right, so we keep piling up other drugs, adding them in order to, contain the side effects from the previous drugs, and we keep creating more issues. And then separate, again, diuretic use on long term can cause kidney failure too. And I always say, I have patients who come, well, I need to see a kidney doctor. I need to see a kidney doctor. I said, what's the purpose of seeing the kidney doctor? Okay, it's caused all because you have congestive heart failure, and because I have to use a diuretic. You should see the heart doctor that's extremely careful of designing a diuretic regimen that's used at a minimum with maximum benefits. And that includes the patient actually cutting the need for it, which is salt intake. So if you don't do that, the nephrologist won't help you. The only time nephrologist will help you if you need dialysis. Okay, I'm wrong, don't minimize that. They do a wonderful job. But I'm talking about if it's caused by congestive heart failure and the need to use the diuretics, this is a cardiologist's business, but the answer shouldn't be just to keep going up on the diuretic, but actually cut the sodium so I can cut down on my diuretic dose and frequency. Okay, all right, and if your potassium magnesium falls apart and you have a defibrillator, the heart can start to go out of rhythm. You can have atrial fibrillation goes fast. You can have ventricular tachycardia. Then you get shocks. And we call this they're appropriate shock, but it's inappropriate because it can be prevented. Because nobody has fun getting a shock. How many of you have gotten shocks from the room? Okay, no fun, right? Some of you will just pass out and then you don't remember. But most of you, we will remember. It's extremely painful. So it's good to have them there just in case, but it's not good to to use it, particularly if you're not going to die. It was just caused by low potassium magnesium. All right. So I'm summarizing here. If your option is to remove the sodium that you excessively put through your mouth through the diuretic, you're going to get gout attacks, you're going to get stomach aches, leg cramps, ICD shocks, and kidney failure. Or you can just cut the sodium. You can choose poison or for free eating healthy, all right? But that's how it goes, all right? Now, there are a couple of tricks. I told you, hey, we can actually use less frequency. Most of my patients who see me, because I get onto them how to eat and cut the sodium, I give them my Sorescu glasses of how to reduce the sodium maximum and keep the good taste. They actually only on once every other day or sometimes every third day, sometimes every fourth day, as opposed to most of my colleagues will put you on everyday diuretic. How many of you takes every day the diuretic? All right. So I can promise you that if you do better job with the sodium, you don't have to be on every day, not even every third day. All right. And I have patients who are extremely sick. All right. So this is important. That's what's in it for you. Okay. Doesn't mean you never have to use it, but there's a trick. For example, to increase twice more, so with the same dose, you actually get twice more effective in eliminating the salt and the water. Basically, just remember, if you walk around and your blood goes into the muscles, not in the kidney. Muscles don't pee. So take it and try to get a little power nap or lay on bed for an hour or so until you start peeing. All right, so pick it in a moment of the day that you can lay in bed after you took it. The second rule is take it on empty stomach. Food blocks its effect. So remember, no matter what, once you give it, you're already hurting the kidney. Kidney will produce more neurohormones, and tomorrow you'll retain more salt and water, but you might as well also decongest. So that's another trick. Take it on empty stomach, and depending what kind of social life you have, I recommend, either you take it first thing in the morning as soon as you wake up, 5, 6, you went to the bathroom, take the water pill, go back to sleep, and then, you wake up and you eat your usual breakfast after that. But you start peeing and you already got it going, all right? And you're done by 8 or 9. Or you take it, if you work during the day, you take it at the end of the day, but not too late, maybe around 5 o'clock. I have a rule of 5 o'clock pee instead of 5 o'clock tea. Why? Because you're done peeing by 10 o'clock, okay? Before you have your dinner and you lay in bed, get a little power nap or rest, and then you can use it that way. And some of you are taking twice a day diuretics. Is that correct? Who is taking twice a day? All right. There is no need for that. That's just a myth. And probably you notice that the pill at night works better than the pill during the day. Or depending if you're a night owl, maybe the other way around. But anyway, that's bottom line. In other words, the pill that you take when you can actually rest in bed will be more effective than the pill that does it. So you can actually take it all together, all at once, in one given moment of the day, and you get more out and faster, okay? Now, I know I'm going to have plenty of doctors who will contradict me. They have zero evidence to contradict me, I can tell you. That's just something that was developed originally as a thought by the company who came up with the last 6 hours. They put that in our brain. All right, and the truth is it doesn't last for 6 hours. It can last for 5 minutes, or it can last all the way for 24 hours, depending how much fluid you have there. It's irrelevant. But of course, they wanted to send more pills. So they, oh, you gotta go. If one doesn't work, take it 2 times a day. Then take it 3 times a day. Take it 4 times a day. So you sell more pills this way. Or I'm trying to figure why would they say that. But anyway, it doesn't really make any difference. We have a study was published recently that they gave it as a continuous infusion versus just a bolus. It really didn't make a difference. The only thing matter is total milligrams a day that you took. All right, so make your life easier. Take it once a day, just accumulate them together. Of course, don't just do it because I said so. Negotiate that with your doctor. Hey, I would like to try it this way. Let's see if it works any difference. And there's no reason doctor will say no. And then you can pick and choose which one works better. Okay? All right, so side effects, dehydration, how do we recognize that? Sometimes it's very difficult because as a patient with congestive heart failure, in general, blood pressure will be on the lower side. So the blood pressure is already low. I'm dizzy kind of all the time. I could be dizzy because my heart is weak, or I could be dizzy and you have plenty of fluid, or you could be dizzy being dry, all right? But it will be similar symptoms like when you have low sugar for those who are diabetics, really. You know, but the most important symptoms when you stand up, not at rest. You are dizzy when you just stay in bed. That's got nothing to do with dehydration, all right? But if that actually has something to do with, you have vertigo. Your inner ear is messed up, okay? But if you have dizzy when you stand up, that could be a sign of dehydration, all right? And you can go anywhere between just lightheaded or feeling like a blackout or black spots in the eye, all the way to literally passing out, all right? And if that happens, if you feel like that, just lay flat, lift up the legs, tell somebody to give you 3-4 glasses of water, it will go away in half an hour, all right, or less. That's a simple, so you don't actually get into the stage of passing out. And then you contact, and then you go back and say, hey, maybe is my weight too low, maybe I overdid it with diuretics. You can hold that until you see the doctor. You can negotiate that, all right? And for us, it's easy to identify because in our heart failure clinic, our nurses will always check the blood pressure when you're horizontal but also vertical. So if the blood pressure drops when you go vertical, you know, then I know you're dehydrated. But if it doesn't drop and you're still dizzy, it may have nothing to do with the diuretic. Something else may be going on, okay? So I hope I motivate you enough. As much as I enjoy prescribing unlimited amounts of diuretics, it comes with major side effects, and it's actually way easier and clear more science and more tolerated if I can restrict the sodium the best I can in this. It's worth restricting the sodium to eat, walk, breathe, and feel better. You want to live longer. You want to stay out of the hospital. By the way, 95% of patients who come in the hospital, they come because symptoms of congestion, which means total body sodium and water is too high. So pretty much, even if there's the only reason is not to ever have to go to the hospital, it's an important reason, because I know patient is not happy. Everybody knows my patients who see me both in the clinic and in the hospital. They know how grumpy I am in the hospital. Doctors are not happy, all right? And then the caregiver, you know, spouse. I mean, it's a major ordeal that you have to come every day, or, you know, getting them in, getting them out. Logistics are complicated, especially if you have to work. So I think each time you think about going and eating at Golden Corral and Red Lobster or any other place, Zaxby is the worst, by the way. It's the southern version of McDonald's, which is 10 times worse. Yeah, particularly the fried pickle. Anyway, but bottom line is, you can do all that, have all that food, just cook it yourself at home. You can have all the junk food you want, just cook it yourself at home. All right, but those are important motivation to think ahead what's in it for you when you go and do that, no matter how amazing it is to socialize. I have some patients, you know, they tell me, well, I got to socialize. You know, this particular woman, she's from Canton, all the way up there. She's retired there. She's very happy, nice community, but she absolutely enjoys going out and socialize. And it's like, well, I can't socialize this. I can't go out. Say, it's very simple. Cook, eat at home, then you go socialize. All right, so you had your dinner before, and you can go and socialize. Let them enjoy. All right, the food, all right? So controlling basically the salt intake is controlling your heart failure. Part of the self-management was to describe to you where the trouble comes from and how you can minimize the effects of side effects of diuretics and really, get it over there, all right? So it's not the water, it's the sodium, as I mentioned, because there's conflicting advices we give you. If you go to anybody else but me, they will tell you, oh, you got to restrict your water. I don't tell you to restrict the water, all right? If you can drink up to 2 liters of water a day, there is no reason, because the water doesn't stay in the system unless you have too much sodium. That's the basic chemistry that we know. And until somebody else comes up with a Nobel Prize how to figure that out, you retain the water. Without sodium, it's just not going to happen. So it's not the water, it's the sodium. You don't have to restrict yourself from water, of course, within the limitations. If you have those hormones that I was telling you about, angiotensin, they stimulate actually your brain thirst. And then you actually, patient with congestive heart failure is way thirstier than somebody who doesn't have that. So and then they start to drink a lot. If you drink a gallon of water, now that's not normal, that's abuse. So then I'll tell you to restrict, but really there is no, that's not a restriction. I just got to get you so you're moderate, all right? So 2 liters, 64 ounces a day, 48 to 65 ounces is absolutely normal. You don't have to worry about restricting unless you really go way out of the norm of more than 2 liters. The sodium is what you need to restrict. Now, every once in a while, usually patients who are in the hospital extremely sick, they can retain also water that has nothing to do with the sodium. That can happen. Either poorly controlled diabetes, because when you're using a lot of insulin, body makes a lot of water when you move that glucose in there. So then you can have a lot of water retention just from you having to use too much insulin to control your sugar. That's one exception. And then I might tell you to restrict a little bit the water there. Second exception is in advanced heart failure, usually you're in the hospital, I'll tell you to retain if your blood sodium is low. That's the blood sodium. Most of the time, you can retain 30, 40 pounds of fluid. The blood sodium stays good. Why? Because that means there's yet another hormone, the fourth one that I didn't tell you about, that's activated in these extreme stages. It's called the antidiuretic hormone, or vasopressin, and that makes you retain water that has nothing to do with the sodium. But again, those are less than 1% of our patients. Most of the time, you don't need to worry about the water as long as you keep it up to below 64 ounces is the sodium. And bottom line is, any amount of sodium, you're going to be positive. For 1 gram of sodium, you're positive. Today, you retain 1 pound of water. So when I ask you to write down your daily weights and then you bring it to me and I see a sudden bump of 3 pounds, in my mind, there is 3,000 milligrams of sodium that you had the day before from eating out or whatever you're eating, whoever cooked. So you don't have to eat out, but suddenly, oh, I had this aunt or cousin who came and cooked for me. All right, well, that's what happened, just different taste. All right, and you need to identify that. It's not the water that you drank extra, it's the sodium that you had extra, and try to avoid that. And the body doesn't make sodium, and that's what it is. Okay, we talk about, there's a lot of also conflicts about how much we should restrict the sodium. If you start Googling, and every year I see more and more, it used to be rare about 10, 15 years ago, but now it's on almost Google search. For every one advice that tells you to eat less sodium, there will be one page that will tell you, no, don't restrict sodium. You need the sodium. And I promise you that's just propaganda from food industry, all right? It's absolutely ridiculous. There's even in our cardiology literature now we have studies showing that, oh, if you restrict the sodium, it's bad for patients with congestive heart failure. And you will have doctors who say, I don't know if that's true, that you need to restrict that. And if that's the case, then you tell that to my patient that just removed 30 pounds of fluid from the hospital, and then they feel better than they felt in 6 months. And then I tell you the only thing that this water pill does, and the only mechanism we know, gets rid of the sodium from the body and it comes only through the mouth. If you have to take a diuretic, you need sodium restriction. It's very simple. There's no other thing that we know. It's just a proper. So most recent guidelines is 1,500 milligrams a day. If you go and see our wonderful nutritionist, they will teach you, well, just try to add everything up. Make sure it's below 1,500 or 2,000 milligrams a day. And I will also tell you that's an impossible task, okay? Because it's not like water where you have 1 cup, 2 cups, 4 cups, 64 ounces, I'm done. You actually don't measure it. You actually guesstimate. You have an idea. Somebody, depending what label you bought, made one attempt to measure it right before they could publish it, or get it on the market just because it's part of the law, and that's it. So it's not real science. As a matter of fact, I always say for 1,000 milligrams that you don't see, you got to double up. There's 1,000 you don't see. All right? And it's difficult. So instead of doing that, add them up, it's 7 o'clock, I'm going to watch the game, I'm up to my 1,200 milligrams allowance. Like, what can I eat from the fridge that's 300 milligrams so Sorescu is happy? Nobody ever does that. I don't know where that came. I don't know why our nutritionists and why our guidelines tell you guys that you got to add everything up. It's just not working, all right? I tried to do it once myself. It took me 4 hours to figure out, okay? And now you might be, I have a couple of patients who are extremely OCD who spend a lot of times, but the only way you could do that, if you actually are an extremely fussy eater, and you only eat 2 or 3 things a day, and you know already what's in there. But unless you limit it to something that's already prepackaged and you know exactly what it is, and you just say, well, today I want to eat this, tomorrow I want to do that, it's just not going to happen. It's too much effort. It's not worth it, okay? So Dr. Sorescu rule is, I don't care what you eat and how much you eat. If you have to use the diuretic, you're eating too much salt, okay? And you could do better than that so I can slow down my water pill, or your weight went up, okay? And I'm talking about sodium salt, not potassium salt, which will be Mrs. Dash. Sodium is the bad guy, all right? And it takes 1 gram salt from diet to retain 1 pound of water. And the trick is, though, I told you we have complicated rules to teach you how to restrict. And we need to come up with simple rules that will allow you, empower you when you go shopping at Kroger, so make it very easy. And everybody knows the rules. Go where the green is, the veggies. Don't middle versus periphery. And that's an okay rule. But at the end of the day, whatever instructions or Google instructions you have, 20, 30 pages from nutrition, you don't go with those and you shop at Kroger. You just go with your mind. So you have to have something in your mind that's very simple that can help you to navigate to 200,000 products that Kroger basically puts every year out, okay? Einstein defined insanity to keep doing the same thing over and over and expect different results. If you keep getting too much fluid and you have to use the diuretics, you're not doing right, you can do it better. But he also said that any intelligent food can make things bigger and more complex. It takes the touch of a genius to actually simplify and make it easy. Now, I am not the genius who came up with these next 2 rules, but I promise you they're extremely simple. And you don't have to be a highly educated person to do it. Anybody, all you need some glasses and read one label that says sodium, okay? And I'll teach you. It's very simple. Or you can do what my boss says. Dr. Andy Smith's rule is, if it tastes good, spit it out. Yeah. Because your taste has gotten used to high salt, so if it's low salt, you're not going to like it, all right? All right. But we can't do that all the time, right? Because you got to enjoy food. So, but really, the next 3 rules that I'm going to show you are actually derived from a simple, 15 years ago when I started to put the first lecture for this, and what advice do I give to my patients, meaningful and extremely simple to use. So I Google humans with the lowest sodium intake, all right? And I got to this website. This is where Google actually helped me, all right? And there is a tribe, Yanomami Indians, that are between Venezuela and northern Brazil, who actually, there are researchers went there, and they measure how much sodium they have. They have no access to sea or anything else, so they don't have sodium. As a matter of fact, if you were there and you sell them salt, they love it, and they will give you whatever else you want to buy. It's like an exchange coin, okay? And they eat, actually, their sodium is less than half a gram a day. As a matter of fact, some of them in the range of 50 to 100 milligrams a day. Take-home messages here. Doesn't matter what you read on the internet. There is no such thing as too low sodium in the body that will negatively affect you. All right? Yes, I'm talking about just from food. Now, if you're taking the diuretic and you're taking poisonous amounts of diuretic, yes, you will have sodium depletion. And guess what? You got to eat salt to counteract the madness of too high dose diuretic as the poison. Then the diuretic becomes the poison, where the sodium becomes the good guy. Believe it or not, we have studies in our heart failure literature has been published. They call it a sodium restriction diet, but those patients were on 1,000 milligrams of furosemide a day. All right? I don't know. That's happened in Italy. I don't know how they passed the test that you can just put that. I mean, anybody who takes furosemide will know that 1,000 milligrams is at least 10 times more than I would ever prescribe, at least when you're at home, okay? So yeah, in that case, the diuretic will be poison. And yes, if you actually let yourself eat the salt, you will counteract and you'll live better. All right, but that's not a sodium restriction study. So the secret they have there to have such a low sodium is actually I went literally and I read their principles. They're a little, philosophy and religion. They eat only food that comes from Mother Nature. Basically, that's how I came up with with the second rule. The first rule is, you can't eat food from Mother Nature if you eat out. So first rule is 89% of sodium comes from eating out. And, somebody else is the cook. You can't control the food unless you cook it, or somebody who exactly how they cook. All right. So of course, me coming and telling you, well, you eat out what, once, twice a day. How many of you eats out every day? I mean, out of your house. You didn't cook. All right, a couple. How many twice a week? All right, more. And how many 3-4 times a week or more? Good. All right. Well, at least they are honest. I know there are plenty of others who didn't raise their hands. They are not honest. Okay. All right. Because it's very easy to eat out, by the way. I mean, and food is good. So don't. I honestly, I eat out about once a month or every few months. Okay. And I'm a busy guy, but we believe at home in cooking, and we do it. And actually, it's because I like that food. I like my food better than what's out there, with rare exceptions. Of course, doesn't mean when I go on vacation, Cancun or whatever, I'll eat because I love that too. But I'm in vacation. I don't do that every day. It's a little different. Doesn't mean you should never eat out, okay? So, but bottom line is, even if you cut from 7 times a week, which is one a day, to once a week or once a month, huge difference. You cut immediately 89% of your excessive sodium intake. By just focusing in eating, say, hey, one day I'll cook, one day I won't. Already big difference. All right? And then if you can cut it down to minimum, that's even better. Just remember my rule of thumb. 1 meal eating out, 20 meals eating home with salt. All right? This is not a joke in average. I mean, a Chick-fil-A sandwich is between 2,500 milligrams and 3,000. And that thing is tiny. You need 2. All right? So just keep that in mind. So that's where it's coming from. So first, single most important effective way to eliminate or reduce is that, by reducing that. Second, then if you don't eat out, you gotta cook. Now, obvious, all bets are off about my rules if nobody cooks at home. Okay, this relies on getting back into our own hands. And, when I mean cooking, you don't have to do, complicate 3-hour stuff that, oh my God, just to, when part of that, what I would advise you if you're reluctant to go back to cooking or even, is, first of all, stop watching TV channels about food and chefs. Yes, because they made it impossible for anybody to ever want to cook again. All right? I mean, it's so complicated. You got to do this. You got to be super expert. I say, who cares? This is irrelevant. It doesn't matter. As a matter of fact, most of what I see there is disgusting. I mean, every 5 seconds, there's another layer of salt and sugar added to destroy our senses. And they sprinkle some more, and then they're the judges who debate this and that. And I look at them, I said, you guys are ridiculous. Obvious, you're not paid enough if you keep raising the salt and sugar in this, stuff. And so first of all, stop watching TV. Get the simplest thing, get a recipe, make a rule. I don't want to spend more than 5 minutes to cook. It's still a big improvement. There are plenty of things you can make it in 5 minutes. A salad takes less than 3. Okay, you just buy the stuff and you cook it yourself, and you can make it super tasty. All right, so that's important, just something simple. But when you cook, though, at home, I've noticed with my patients, some of them don't know what I mean by processed food. Okay, for me, processed food is the same like eating out. It's the same thing. As a matter of fact, when you go to Piccadilly or those restaurants, you don't realize that actually nobody cooks there. They have already the stuff that's frozen, pre-packaged, pre-delied, and then they just mix it up in the microwave and bring it to you. All right? Which you could do the same at home. You might as well buy, the ones from Kroger. There, at least you know how many milligrams of sodium you have and all that. So, but that's important to know. It's not real cook. Now, there are restaurants who actually cook everything. You see them. because they have an open place so you can see they're cooking. All right, for example, and I'm not advertising for Rumi's. It's a Persian ethnic kind of place. It's excellent. I go and I eat there. It's our favorite place to go. About when we have birthdays, literally, that's the only time. But it's great. But very few, of course, it's expensive, and the ones who are really good, you're gonna have to stay in line. You can't eat every day that way. But bottom line is processed food, deli products. That's what I mean. If you were to buy sausage, ham, that is processed food, processed meat, processed cheese. Okay, and that's important. Doesn't mean you cannot use it. Just try to use then my third rule, which is if you read the label, this is the only rule you ever need to know if you shop label products. If it's natural, like fresh meat, fresh veggies, it doesn't have a label. If it's not natural and it's processed, it has a label. And if it has a label, look per serving. Sodium less than 100 milligrams per serving. All right? And that's important. All right? That keeps it easy. Sodium, 100. Don't look at the percent. Anybody can memorize that. You can shop, and then it's easy. All right? And then I added the fourth rule because turns out whenever they go down on their sodium, they go up on their sugar. All right? So patients who are diabetics, and I can tell you about 1 out of 2 with heart failure will also have diabetes. You have to pay attention to the sugar too. So I created another simple rule. Total carbs. Don't look where it says added sugar or no added sugar. No, that's cheating. All right? Just look at the carbs because basically the real sugar will be total carbs minus the fiber, which most of the time it doesn't exist. It will be 0 or 1. All right? So total carbs. This way they cannot cheat. That means if total carbs is 15 and your fiber is 1, and then they say no sugar added, that's just a lie because that's sugar. All right? Because the total carb should be fiber plus sugar. There's nothing else. All right? So, and that's okay because they created a little legal trick to do that because you don't have to disclose that you add sugar loss as long as you declare it at FDA that it's natural. So if it's natural, you don't have to put it on a label. Some will be more honest and will say sugar is 5 grams added, and some won't disclose anything and will tell you it's all natural. It is true by the law. It's not true by chemistry and biology, okay? Very simple. So why did I come up with 12 grams? I'll tell you why. Very simple. 12 grams will be equivalent. 1 teaspoon of sugar is 4 grams. So how would you like your coffee or your tea? I think I'm super indulging here to say you can have up to 3 teaspoons of sugar per cup of coffee. I think we're okay there, right? All right. So more than 3 is just exaggerated, and they cheat that because you like it. They actually know exactly. It's called the bliss point, the sweet spot, where if they add enough sugar, you will buy only that product, and absolutely have to be the equivalent of 8 teaspoons of sugar. 32 grams. You'll see every single beverage that you ever like, read that label. And if you keep going for the same product, it will always have at least 8 teaspoons of sugar per serving, at least 32 grams. Check that out. You'll see. They know the science has been done in the 50s by Coca-Cola and Pepsi. They know this. They know exactly what it is. As a matter of fact, they did an experiment. Sauerkraut. Would you drink that for breakfast? All right. You add 8 teaspoons of sugar, you'll love it. Trust me. Okay? And people didn't know. And then, of course, they add some flavor so you don't know it's sauerkraut. And they like it more than the Coke. All right. So now we're going to practice for a few minutes of how to read the labels properly. And the only reason I that is we buy labels. We buy labeled product. You're not going to cook bread every day. You're not going to make your own cereals. Not that I encourage you to eat cereals. All right. So here is bread and Cheetos. Bread. This one has sodium, 140 milligrams. Times, if you were to have 2 slices per each meal, times 6 slices will be 840 milligrams just from this of sodium. Well, meanwhile, the whole bag of Cheeto will be 290 milligrams. But it's a tiny little bag. You probably want 2 or 3 of those. But just in case, it can accumulate. All right? So that's why I come back. Instead of me having to add them up, I'm just going to limit the sodium to what I think will be a low sodium taste. And you'll be surprised. It'll be just fine. Okay? Try that. And there are plenty of products now. You can almost find everything. I found But potato chips, they have 0 milligrams sodium now. So you can find anything. But be aware also of frozen veggies. They are supposed to be frozen natural, but you can have sodium of 200 milligrams. That means when they say they add it for, you see sodium benzoate, that's preservative, and for preserved taste. No, that's the sodium. So you like that more, so you buy that. The piece shouldn't have more than 20 milligrams. So it doesn't matter if it has a label, you could eat frozen stuff, or canned stuff even, although I don't encourage because you're not going to find a lot of canned stuff that has less sodium than 100. But yeah, just use that rule, sodium less than 100. You can find tomatoes, and tomato juice and everything with 0, actually, like pommy, for example, from Italy, but it doesn't have to be from Italy. You can find, just be careful, use this rule, and you'll be fine. Then you don't have to add them up, okay? And then, broccoli, 20 milligrams. And then you can find barbecue sauce that everybody loves barbecue sauce. Thanksgiving is coming. Absolutely. You can find barbecue sauce. Sodium is 15 milligrams. But check it out. Why do we like the barbecue sauce? Because of the sugar, 27 grams. So a teaspoon is 4 grams. 6 teaspoons equivalent per serving, which is a few drops. So keep that in mind. That's why you like barbecue sauce. Okay? Carbs, basically bread, cereals. You can have bread that's 110 milligrams from Publix, or you can have the one that's 220. But you see, and this one doesn't have actually that much carbs on it, because if you subtract the fiber, it's actually okay. But you can find cereals that has sodium of 300 or sodium 0, shredded wheat. But now I taught you, hold on a second, I'm not going to look only at sodium, because cereals, they will take the salt out, they'll put the sugar, right? So let's look at the sugar. 40, 46, right? 46. And the fiber is only 1. So if I subtract, most of it is just sugar. So it's anywhere between 8 to 9 teaspoons of sugar. No wonder you like Raisin Bran. But you're not having cereals. You are having 8 teaspoons of sugar. That's why you like it. Might as well just buy sugar. It's cheaper, and put in water and you're done. Yeah. Or milk, okay? All right. It's not a healthy product. It doesn't matter. And then American Heart Association may endorse it for the cholesterol, but I wouldn't endorse it for the sodium or for the sugar part of it, okay? All right. So how to manage heart failure now? After we went through all this, what's causing issues, what doesn't, we talk about, medicines. How to minimize the side effects. What do you do at home when you are there? Number one is, I think anybody who can just get heart failure, obvious, if you complain about side effects of the furosemide, you need to have a scale if you want to minimize the side effects of that. So you can catch when you eat too much salt, all right? So by a scale, a blood pressure machine. I recommend the ones for the arms, not the ones for the hand, okay? Those are more reliable. Record every morning your weight, and when you wake up in the morning, blood pressure, pulse to bring to the doctor appointments. Also come with the medications. Don't come just with the list of medicine. Oh, you guys have it in the computer. Well, you'll be surprised if you already went to the hospital. Hospital gave you some medicine. Then we had different ones that we recommend. Then it's a mess. I can't clarify and reconcile the medicines. Always come with the medications so I can look at them. Makes a difference. Good blood pressure, you want to be around 120 over 80. If it's way higher, 150 over 90 is not good. If it's too low, 90 over 60 or less, and you're dizzy, then we might need to adjust the medicines. If you have diabetes, record your sugar too. If you can afford buying a Fitbit or an Apple Watch, do that. Fitbit you can find now for $60, and it's extremely useful because you can have, it will tell me how much you move. I know if you move less compared to what you moved before, and really a minimum you should do 2,000, 4,000 feet a day, which is 1 to 2 miles. A mile is 2,000. Ideally, you want to get all the way up to 5 miles if you can walk a day. It's a good thing, all right? And these devices track not just how many feet you did, and also motivates you actually to do more walk, but also they now can track the pulse. If it stays high, you see some spikes, you might want to let us know if you have a device, we can also check it, but particularly if you feel like you have a fast irregular heartbeat. You shouldn't have a pulse of 110 at rest when you don't do anything, all right? And we need to know about that. And then you tell us, and we can ask you to download some information, and then we can tell you if you have arrhythmia or something else is going on. If we know if weight goes up by 2 to 3 pounds, you can double your water pill that you take and then let the doctor know. Just don't rely only on the fluid in the legs to tell you if you have fluid, because by that time it gets there, you already have 7 to 10 pounds they have accumulated. Be more critical of what and where you ate the day before if you did gain that weight. That means, I may do better next time so it doesn't happen. And if the weight doesn't go back to normal, obviously you need help. Either something else is going on, we need to increase the diuretic. And if you feel dizzy, maybe you have weight lower than usual, maybe you have too much diuretic, that means you need to step up on the water. Particularly elderly, 65 years old, 70 years old, older, we stop drinking. We don't realize, but we drink less and less and less. You need to go up and drink your 48 to 64 ounces, 6 to 8 cups a day of water. That's important, particularly if you're on a diuretic. All right, that will evolve. And dehydration doesn't necessarily have to manifest as dizziness. It could be just general tired and fatigue, and I don't feel like getting out of bed. And then you have enough fluid, and suddenly you're like an energizing body, okay? So it makes a major difference. It's important, all right? If you develop now any kind of infection, it's important to tell us. Why? Because any kind of infection will activate more of those neurohormones that are bad and will aggravate suddenly everything. It's extremely important that we need to identify early a urinary infection if you have burning or foul-smelling urine. If you have any cough, upper respiratory infection, virus, let us know right away. You want to catch it early to avoid from becoming complicated. If you develop any kind of joint ache that is nagging, stays there for more than a day or two, that could be gout attack that's happening, particularly if you are on chronic diuretics. Let us know. Don't take a leave or Advil or Motrin. It will make it worse. It will make you retain more salt and water, and it's not good for the kidneys. You will also, any kind of infection can drop your blood pressure. So you're already on blood pressure medicines, right? Like Sinopil, the sartans that I talk, then your blood pressure goes down to nothing. You'll feel terrible, fatigued, tired, like you're dehydrated, but yet you actually will retain more fluid. And you'll see that the water pill doesn't work. So a lot of times, we actually advise you to, I will hold the other medicine, the lisinopril, the Entresto, I don't care, until you get over the infectious part, and then we can introduce it back. Why? Because fever and infection causes vasodilation, relaxes your artery, and drops the blood pressure per se, and steals the blood away from the kidney. So you see two different conditions. They can fight with each other. We need to be aware, and I know when to minimize so you don't get side effects from my medicine. All right? Keep your appointments with the doctors. It's extremely important. Not because it's the only reason I make an income. No, that's not why it is. But it's important because I can see things. I can clarify some medications that could be completely missed. And I have patients many times, they'll say, well, you didn't refill my medicine. I said, okay, well, how would I know? I have 3,000 patients. I said, well, there was 0 refills. That means you don't want me to take it anymore. So a year later, no medicine, ejection fraction dropped like 10%. I say, no, that's not how it works. Even when you see there is no refill, call us and don't call the pharmacy. And pharmacy will volunteer. They'll tell, oh, we'll call. It never works, or very rare. You might have a super zealous pharmacist. You need to call our office, so then we send them orders. Then you have your medicines, okay? And that's important. And bringing the medicine, I said it's important. One thing that I always emphasize, we have evidence for that, ideally try to come with somebody to the doctor. All right. As a patient, if I'm the patient, we cannot assimilate all the information and advices that the doctor tells us. But the coach or whoever is the significant other has a free mind of any stress to actually record much better. Even if it's written there will be essential stuff that you could be missing. Also, you'll be your coach to implement what the doctor tells you, even if you may not like it when you go home. All right. So advice. So always the best case scenario is when I see, of course, a patient with a spouse, usually a man with a wife. Then I know I'm good. I don't have to worry about it. Somebody's going to record everything. All right. The worst case scenario is a single man, usually young. I know nothing is going to happen. It doesn't matter what I tell him, no matter how intense he's going to get about that. It takes a lot of motivation. It's just not going to happen. Women are wonderful caregivers. Now, the catch with the woman, the single woman, is the next in line being worse, a little less worse than the single man. Why? You ladies are wonderful caregivers, but you are terrible at taking care of yourself. This is the ugly truth. You're more reluctant often because you've been in. So don't do that. Just, I always say, see the doctor so you can prevent from things getting worse later on. It's the same thing. So come with somebody at the appointment. And that somebody shouldn't stay in the waiting room as long as somebody you care about and you don't mind sharing the information. Get them in the patient's room, with you. If pharmacy, I told you about the pharmacy, don't rely on pharmacy, call us when you see 0 refills there. And you can check. Sometimes indeed, I just want to give you, 7 days worth of antibiotics. I don't want to repeat that again, all right? I get it. But if yours a pill that you've been taking for 3 months and suddenly there is no refill, something is not right. Let us know, okay? Now, one thing that we are terrible as institutions and doctor's office, we give you those generic numbers. When you call, you literally have to go through a menu of 10 different numbers. It takes about 5-10 minutes to figure where you end up, and often there will be nobody on the other side. There will be some generic operator who doesn't know anything about your situation, nor can talk in that moment with the nurse. Ask wherever you go to get the direct number from the clinic straight to the heart failure nurse or whoever is the nurse managing your situation. Tell them to get around that. And I know Tiara is going to be upset with me. This is our direct number, 446862840. This way you skip all the other complicated stuff. You're going to get 90% of the time a human there. If it's not a human, it records on voice mode that translate action a computer email that we can see it and we can check it right away. All right? But try to get that. Doesn't matter what clinic you go to. Try to get around and find the direct number from the secretary that's actually physically there. And be nice to them. You'll be surprised. They're your best ally. Okay? All right. Monitoring, remote monitoring. And this is pretty much will serve as an introduction for Caroline. Just all this stuff that I taught you, weight gain, 2 to 3 pounds, is good, but it's not as good because it's only 20% of the patient will actually have a gain weight. They can still be sick and they don't know. Okay, it's not always reliable. We have other ways actually now. If you have a device, how many of you has a pacemaker or defibrillator? All right. Oh, all right. I guess it is an ICD meeting. So bottom line is those devices are so smart now that I can monitor. You can send a download. Okay, and I can actually look at the fluid accumulation in your lungs, even if you don't know about it, you don't see anything. And it's extremely sensitive. You see how this little blip going up? It measures basically, as soon as there's fluid in the lung, measure the resistance to the current. That's inverse proportion with the amount of water in the lung. But not only that, but our wonderful device managers from Arrhythmia Clinic, they can also see if you have an arrhythmia. Sometimes you may not feel those palpitations or irregular heartbeat. All you do is just the heart is racing, you have no idea, and then suddenly you start accumulating fluid. So I can see that you are in atrial fibrillation. That was before you actually started to accumulate fluid. The heart decompensated, and then 2 weeks later, you're in the hospital, already advanced heart failure. So that can happen, all right? But now doctors have other tricks that can get me more sensitive. We can actually get a blood test that will tell us if you have walking around with a lot of fluid you don't know about. It's called a BNP. Ask your doctor about BNP, okay? Basically, it's a chemical test to know if you have too much fluid or walk around or your heart is under stress. BNP, it's our own hormone, the good hormone. Remember when I told you, as soon as your heart is not good, then the brain and the kidney start to divorce the heart, will start to throw whipping bad hormones at it. Now the heart fights back with another hormone trying to counteract those guys. And this is what BNP is. It's actually a measurement of all neurohormone activation and what's happening if you have salt and water retention. So we can check that and we see has changed. That's important, all right? Of course, if you pass out and you have a defibrillator, you better call the clinic so we can download. If you actually get more than, if it's one shock and you feel okay, maybe you can wait. You can just let them know and then go to doctor. But you get more than 1 shock, 2 shocks, you better check to ER or if it's off hours or call the clinic, go right away to the clinic because often there's a simple blood test we need to do. Check the potassium, magnesium so we can put you back in track and reduce the water pill, all right? But sometimes, or if you have diarrhea, don't stay with diarrhea. You will get ICD shock, all right? As soon as you get diarrhea, it's more than a day, call the doctor to work on the diarrhea and stop it. It's very important. All right? Because you'll lose your potassium, magnesium. If you hear a beep from device, Caroline is going to address that. Most of the time it's benign. The device is trying to tell you something is going on, but it's not necessarily an emergency, although sometimes it could be. It's end of life for your battery. But Caroline will walk you through that. If you get incessant hiccups or see muscle twitch where you have your pacemaker, it may be that you have false, you need to readjust the pacemaker. So let us know. All right. And this is our direct number from the arrhythmia clinic, at least at Midtown, 44686-2500, if you have any issues related to the device. All right. Or you feel funny. Okay. How are we doing with time? No, I don't have time to go for the Mediterranean part, right? We'll leave it for some other time. Right? How about I stop here, I'll take some questions, and then Caroline will go in the next step. All right? Okay, plenty of questions. Go.